Hey guys, sorry. Oh, here we go. Trial's finally loaded up. Sorry guys, hanging tight here. Hanging tight, please. Work with me. All right.
Out. I introduced him to the nurses, showed him the EMR, our on-call room.
This guy's on Zoom, a witness. He must be sick or something. COVID issue.
Then
Keeps the case going.
Started with as alternating shifts with me. It's about like 1 week on, 1 week off. Then I also met with him in multiple meetings with Dr. Swanner and Dr. Ralston.
Did the two of you have the capability of communicating in between shifts if you needed to?
Dr. Husel, he didn't have a cell phone, so he had an email, and he was really good about responding to his email. So every time I send him an email, he would respond to me in like 3-4 hours.
Did Dr. Husel ever ask you about palliative withdrawals or palliative ventilator extubations?
No, we never talked about any patient management. Our talk was about coverage, because I used to ask him like to cover me when I go to Egypt, when I went to get married, and he was so nice to cover me all these times. Plus, our talk was also about our contract renewal, but I don't recall at all that we talked about any patient management.
Dr. Hagris, during the time you've been with Mount Carmel West in the ICU, had you ever had the opportunity to perform a palliative withdrawal or a ventilator extubation that was palliative?
I'm sorry, say it again?
Sure.
To what?
During the time period that you were employed with Mount Carmel West as an ICU doctor, did you ever perform a palliative withdrawal?
Yes, ma'am.
Tell us what you would do in that type of circumstance.
Well, the most common scenario in my practice is a patient has been in ICU.
Hang on, there's an objection, sir.
Relevance, and this is the issue that we discussed.
Okay, I'll permit it.
Go ahead, Dr. Hagris, you can answer the question.
Okay, the most common scenario in my practice is a patient that has been in the ICU for like some time in ICU, days or weeks, and there was an ongoing discussion with the family, and the patient, like it's either the patient declines in my shift, or the decision already made before my shift, but the family gathers in my shift and they decide, okay, we are ready, and I am the one on call. So I go in and I confirm that we are on the same page, and I change his code status to do not resuscitate comfort care. And I explain to the family the process of the extubation, that I'm going to stop all the infusion 30 minutes before taking the tube out. I'm going to give a dose of morphine and Versed 10 minutes before taking the tube out. And after taking the tube out, he will have a comfort oxygen. Then after that, every 15 minutes, he will get morphine and Versed till he passes. And during this also discussion, the nurse will be here. I offer also a chaplain support. And like after he passes, I will come back and pronounce him.
Okay, so just a few questions off of what you just told us. You said you would order a DNRCC. First off, what is a
Yes.
DNRCC?
It's a do not resuscitate comfort care.
Okay.
Do not resuscitate comfort care. And this is like when I perform any palliative withdrawal, I do that. So this means I'm not going to perform any line of treatments. I'm just comforting the patient. So I'm taking the tube out and give him medication and some oxygen. And this is what's DNRCC.
Okay. And you said you place you order it. How do you place that order?
Well, there's an order set for palliative ventilator withdrawal, and there's a check box that I can change it to DNRCC. There's other check box. If I remember, it's to take the tube out. Check box to contact loop organ donation agent. So it's part of the order set.
Okay. And you said you go in and you check it. Is that on what you call the EMR, the electronic medical record?
Yes, ma'am.
So that will physically show up as a order in the medical record?
Yes, ma'am.
Okay. And
Yes,
you
ma'am.
referred to an order set, sir.
Yes.
All right. Jose, this will be the first one for the order set that I handed you. That's from 12/7/10 to 8/17/16. All right. Sir, I'm going to show you in a second, as soon as I get to the right screen, what we have marked as States Exhibit 17A, as soon as it pops up there. Can you identify this for us?
Yeah, this is it's date 12/7/2010. Okay, and this is revised terminal ventilator withdrawal plan of care. Okay, yeah, this is what I'm using to communicate order patient withdrawal support.
Okay.
Yeah.
So this is what you called the order set, am I correct?
Yes, ma'am.
All right. And you pointed to the date 12/7/2010. Am I correct? That's where it begins. And then this policy went through August 17th of 2016.
Yes, ma'am.
Where did you access this at Mount Carmel, sir?
This order set?
Yes.
Yes, this is in our electronic medical records.
Okay. All right.
The #1 movie in the world is Uncharted. Forbes magazine is calling it a rush.
Did I not mention that?
No, you didn't. And has a 90% audience.
Yeah, this is the beginning of the order set. So if you can scroll down, so I need to check the box, these boxes. So I will check these first 3 boxes. Okay. So then when I go to the medication, I will find where I can give 10 minutes. Yeah, this one. So so I will check the first box, pharmacy. The patient is on.
Sorry, I went to the good feed again, guys. I apologize.
before taking the tube out, and I will check the second box, the third box, or third box. Then I will choose. No, sorry. No, I will check the fourth box. I will use maybe. This is when. Okay, so no, sorry. I will check the third box for the first hour. Then I would choose like maybe 4 milligram every 50 minutes. Then the fourth box, I would check it if the patient survived for more than 1 hour. I will check 4 milligram, and I can choose between morphine and dilaudid, and I always like choose morphine. Sometimes dilaudid, but mostly morphine. And then I will scroll down to get to the Versed, and yeah, Versed injection. This one I will check it, and it's 2 milligram IV, and this is, yeah, I will tell the nurse to give it also with a morphine 10 minutes before taking the tube out.
Okay.
And if you can scroll down,
Yep.
if you can scroll down, and okay, then I will check the Ativan. Here it's 1 milligram every 15 minutes after taking the tube. Then I will check the Ativan if he survived more than 1 hour, 1 milligram every 4 hours after first hour if he makes it after 1 hour. Then I'm going to check the Atropine for any increased salivary secretions. And I'm going to check the oxygen therapy, and I'm going to specify it's 2 liter oxygen for comfort. Then I would sign up. I would sign with my name, and I'll just put it through. Yeah.
Okay. So all this would show up on the EMR.
Yes, ma'am.
Now, you said first that you stopped the paralytics 30 minutes before. Why do you do that, sir?
Well, because I need to assess the patient to see if he is in pain or any air hunger after taking the tube out. So I need to be sure that paralytics are out of his system so I can get an accurate assessment.
All right. And you indicated you usually start with, did I hear 5 milligrams of morphine? Or did I say that incorrectly?
Yes, 5 milligram, 10 minutes before taking the tube out, with 1 milligram of, or 2 milligram versus also 10 minutes before taking the tube out.
All right. And just so I'm sure I know what you're talking about, Versed is the brand name for midazolam, am I correct?
Correct, ma'am. Yes.
And the Dilaudid is the brand name for hydromorphone.
Correct.
You mentioned the atropine for secretions. What does that mean to us?
For salivary secretions, some patients, when they take the tube out, they will have a lot of saliva, and this will give them a lot of discomfort. So we give them atropine to dry out these secretions.
The end there says oxygen therapy. Explain to us what you do on that.
It's a nasal cannula. It's a 2 liter nasal cannula. Okay, we put it for the patient for comfort.
Okay. And then you also mentioned extubation. Are these patients on ventilators typically?
Typically, yes.
So what do you, describe to us just briefly, when you say extubation, what are you talking about?
I'm talking about taking the tube out. So patient will get a set of medication 10 minutes before taking the tube out. Then the nurse and the RT will be there. They will deflate the balloon. Then they take the tube out. Then they will put the 2 liter nasal cannula on.
Okay. All right, and we've talked about several medications, morphine, Versed, Dilaudid, Ativan, Atropine. Is fentanyl anywhere on this palliative order set?
No, ma'am.
Dr. Hagris, are you familiar with the conversion rate between what would 1 milligram of morphine be as far as how many micrograms of fentanyl?
1 milligram morphine, it will be equal to, I think, 10 microgram of fentanyl.
All right, so if I go back up here, sir, I'm just going to go back to the first page. So if you're starting, let's even go with 10 milligrams of morphine. See how good you're at math. How much?
It's,
I'm sorry, go ahead.
I'm sorry, it depends on the patient, you know. When I assess a patient and I see, like, you know, what's his clinical condition, what's his comorbid diseases, what's his age, what's his size, what's his body habitus, what's his tolerance to these medication, I decide which dose I will use.
Okay, so if, let's say you chose 10 milligrams of morphine, what would the conversion be to fentanyl?
Objection.
I understand. I'll permit it.
Thank you. Do you remember the question, Dr. Hagris?
Oh yes, 10 milligram will be 100 mics of fentanyl.
Okay. Dr. Hagris, you're still at Mount Carmel West. Has this has this order set changed over the course of time you've worked there?
No, not to my recollection, really.
All right.
Not to my recollection.
Did they adopt or at least update the policy to your knowledge?
No, I really don't know.
Are you aware, Dr. Hagris, of at this time whether there's a mandatory?
Objection. He just stated he's not aware of any changes.
Haven't had her whole question. Let's put the question on.
Certainly. And Dr. Hagris, don't answer this yet, but I'm going to put the question on the record, okay? Are you aware of whether there is currently a mandatory order set for palliative care withdrawal? And hang on a second before you answer that.
Okay, I'll permit that question.
Okay, Dr. Hagris, you can answer that if you know.
No, ma'am.
Okay.
Not to my knowledge.
Dr. Hagris, have you used that order set throughout the time period you've been with Mount Carmel?
And even before Mount Carmel, in my prior job in Atrium Medical Center, we started with Epic, and I started using order sets. So when I came to Mount Carmel, I had the mentality to use order sets. So when I came, I created all my favorite order sets for all kinds of treatments, including palliative withdrawal.
And can you estimate approximately how many palliative withdrawals you've done during your time with Mount Carmel West?
I don't have an exact number, and it's just hard to estimate, but I would say maybe 15 to 20 ones a year, but it could be really wrong. So I really don't have an accurate number.
Have you always used that order set when you're doing a palliative withdrawal?
Yes, ma'am.
Have you ever had an issue with the patient while using that order set?
No, ma'am. Because the patient will get these medication every 15 minutes.
Okay.
So he will get enough of these medication, and the patient will get assessed every 15 minutes. So if the nurse has any concern, she will call me and I can adjust the dose, but it's rare to happen.
Can you think of what the maximum dosage of morphine you've ever used is in a palliative withdrawal?
Well,
Objection. This is again.
Okay. Maybe we should sidebar it real quick. Ladies and gentlemen, entertain yourselves.
Dr. Hagris, we're going up to see the judge, so just hang on for a minute, okay?
So yeah, we are. I'm not actually sure what the sidebar is going to be about because I don't really know. I think this is somewhat relevant testimony here, but I think they're trying to get through. There are doctors who do the palliative care, who do the end of life care, and if you guys are reading along with that, they have a process to basically kind of kill you. And he was not following that; he wasn't doing it. So I think they're trying to show there is a right way to do all of this. Because I know earlier Jose Baez was claiming, well, there's no rule. So that's where we are with that. Yes, thankfully, Marble Mouth is not doing the closing argument for the state. I clicked over to that on a different window. I'm not going to go over to that. Like I said, it's going to be boring and take forever. So we're stuck here with this today, guys. How's everybody doing today? Hopefully well. Didn't see if you guys had any questions at all. Sorry, guys, just responding to an email real quick. So yeah, it's let me see here. It was the pharmacist's business. Yeah. Like I said last night, I don't okay. I find this trial hard to follow with all the numbers and this and that what's going on. How do you think the jury it's easy if they could just say, yeah, he gave him a ton of fentanyl and these people died. But at the end of the day, they have to prove that these were fatal doses and fatal amounts, that other people, there's a way to compassionately kill someone according to medical procedure. So if he was really doing that, here's how we would do it. They're trying to show he wasn't following any of those rules or guidelines. He was acting on his own. Um, when you're presenting a prosecution of a crime, it's a lot different. You're telling a story, and I don't mean that in a bad way, like you're making it up. You're literally telling a story, the story of what William Husel did, at least your theory of it. So, yeah, benzofentanyl is lethal. So, Stacy, you're not at all being a dumbass, I promise. But think about it. You have to tell a story, and the story is, how did he kill these people? Well, like a good story, you have to lay some background. And this is them laying background information. Because otherwise, do you really know how much fentanyl could kill someone? Did you even realize how much 1,000 micrograms were? Did you realize how they administer it? What's going on? Who approves it? The whole process involved. That's how you go forward. And that's how the state's trying to prove things. So I don't blame them for doing it this way.
Okay, we're gonna continue.
You have to lay it
Dr.
all
Hackett?
out.
I'm sorry.
So it can get very boring.
All right, Dr. Haggers, I believe I asked you if you had ever had a problem with a palliative withdrawal patient when you're following that order set.
No, ma'am.
All right, Dr. Haggers, I'm actually gonna talk to you now about some of the patients you have treated that our case is involved with. So give me 1 second to switch files. And we're going to start with Ryan Hayes. Let me share a screen.
Laura, you wouldn't need
Give it a
Narcan
second
for
to come
people
up.
because you're in a hospital. There's a presumption they would properly
All right, and Dr.
administer
Haggers,
stuff.
this is what I have for the record marked as Exhibit 2C. And can you identify off of that the patient we are referring to?
It's Ryan Hayes, and his date of birth is 5/15/77. He
Does
was
this-
admitted on,
That's good enough.
That was what I was going to ask you next. You're ahead of me. Does this document show what date he was admitted to Mount Carmel West?
yeah, he was admitted on the April 2nd, 2017.
And does it show which date he was discharged, sir?
Yeah, he was discharged on the April 4th, 2017.
All right, and I'm going to skip down a second to, it's going to be page 5 of my document. So give me just a second. All right. And Dr. Hagris, I am going to refer you to this page, which I currently have up. Did you have involvement with him on Mr. Hayes on April 2nd of 2017?
Yes, he came to ICU and I saw him and I was a critical care consultation. I was a critical care consultation at this point, yeah.
All right, and tell me what a critical care consultation means to you, please.
Means managing the patient ICU from hemodynamics standpoint, from ventilator standpoint, and managing like all kind of electrolytes abnormalities. If he needs any medication to support his blood pressure, support his heart.
And you use the word hemodynamic. Tell us what that means, please.
Hemodynamics means blood pressure, heart rate, and oxygenation. So these are all the hemodynamics that are managing these patients in the ICU.
Okay. And I'm going to scroll down the page here a little bit to the next page. Can you tell us why you were seeing Ryan Hayes at this time, as far as what his circumstances were?
Well, the patient presented to our emergency room because of cardiac arrest. He has IV drug abuse history. His sister found him in the bathroom, and he was pulseless. So she called EMS that they start resuscitating him, and he got 5 runs of CPR along with medications and shocking. Then he came to our ER. His blood pressure was low, so they started him on a pressor medication called Levofit to bring up his blood pressure, and they give him a bicarbonate, and of course he was intubated. I didn't put this in my note, but I assume he was intubated. So I talked to his sister in the waiting area, and I showed to her what I found in his CAT scan, and she
Okay.
agreed.
Dr.
to-
Hagris, I'm going to stop you for a second. There was an objection.
He said, I
Okay.
assume he was intubated. I think we need to make sure.
I think I'm fine with striking that part at the moment. I'm sure we'll get to that as we go further down.
Disregard his assumption.
All right, go ahead. I'm sorry, Dr. Hagris. Go ahead with what else you found at that time.
And the CAT scan of his head, I explained the findings of the CAT scan of the head to her, and she agreed that she agreed to change his code status to do not resuscitate CC arrests, which means the
Thank you.
patient will receive full treatment. Patient will get all kinds of treatment, but in case his heart stops, I'm not going to do any resuscitation and let him go in peace.
Okay, so that's the difference between the DNRCC arrest and the DNRCC?
Yes, ma'am.
Okay, all right, I'm gonna scroll down a little further. I want to talk a little bit about this general area. What does that mean to us?
General area means like, what is vital signs, when the patient comes to ICU. And so I reviewed all these, vital signs. Vital signs means blood pressure, heart rate, oxygenation.
When I look at the I section, what does that mean to us, pupil dilated fixed?
Means really, it could be early because he has a cardiac arrest, and some patient will have this dilated fixed pupils that it can be reactive later on, or he will have, because of his cardiac arrest, he could have severe brain injury, and this is reflected in his pupils with a dilated fixed nature.
All right, and what about the
So,
neurological finding?
Yeah, when I have any patient comes as a cardiac arrest, I need to assess him if he has any response to verbal or painful stimuli, and I also assess him to have any coronary reflexes, because these are signs of a brain injury. Okay, so one important factor when any cardiac arrest comes to ICU, I need to see if he has any brain injury or not, because this is the most prognostic factor. And these are all signs I'm looking for in my exam.
And what did you find regarding Mr. Hayes, sir?
He was not responding to any verbal or painful stimuli, and he has no coronary reflexes.
What does that tell you as the doctor?
Tells me he has some sort of brain injury.
And when you say not responding to painful stimuli, what does that mean to us as lay people?
Well, when I try to squeeze his shoulder, like he doesn't grimace.
So would I be correct in saying he's not feeling pain at that point?
Objection. Again, asking for.
Yeah, I think we're getting that close there. Let's rephrase the question.
So what does that mean about Mr. Hayes's ability at this point to feel any pain?
Again, it's the opinion she sees.
Wow. Rephrase the question, okay?
So Dr. Hagris, what does that tell us, not responding to painful stimuli?
Again.
This,
Hold on.
this means from my,
Doc,
I'm sorry, should I?
Okay.
I got my mic off. Okay, doctor, when you see that in your performance of your duties, what does that mean to you?
This means to me that this patient will have, most likely he has some sort of brain injury.
Okay. All right, and I'm gonna scroll down a little bit further. Did you reach a diagnosis?
Yes, I put in my assessment plan, he has a cardiac arrest, most likely due to drug overdose.
And what is your goal with him at this time?
My goal with him at this time is to just support him, and neurologists should come to see him next day. And the CAT scan also showed he has a diffuse brain edema.
And what
So
does that
brain
mean?
edema, means it's a diffuse brain swelling, and this is a one of the 4 signs when a patient of cardiac arrest comes to a hospital. Means because our brain cells cannot sustain more than 5 minutes or 10 minutes max without a good blood perfusion. After this, the brain cells will die and will swell, will cause this brain swelling. And when a patient has a diffuse brain swelling, this is a really poor sign of survival. And so at this point, I was supporting him. He was intubated,
Okay, hold on,
and
Doc.
Hold on a
Hold
second,
on.
Dr. Hagris, there's an objection.
Okay.
He's getting across the line. I sustain.
Sure.
Let's ask him a new question.
All right, I'm going to move on, Dr. Hagris. I want to go down to page 13 for a second.
Okay.
All right, and I want to direct your attention to, hang on, I got to go up just a little bit. Hang on. All right, I want to talk about this top, and it's labeled order. Can you explain to us what this is?
It's a palliative care consultation. And this is when a patient with cardiac arrest comes, I put an order for palliative care consultation, especially with a poor outcome.
And when you say palliative care consultation, what does that mean you're actually doing?
It's a consultation to the palliative care physician, Dr. Phillips St. Emma, and to come and be involved in the discussion with the family to address the goal of care.
And you place that after the consultation with Mr. Hayes?
Yes, ma'am.
Then I want to go down to page 15 for you for a minute. And again, it's an order, but I'm going down to the bottom one. Tell me about this order, the Dnrcc arrest. Tell me about that, please.
Well, when I talked to his sister and I showed to her the CAT scan finding, she agreed that, this is a poor sign, so I changed his code status I didn't change. I placed an order to make his code status do not resuscitate arrest. And do not resuscitate arrest means he will get a full treatment, but if his heart stops, we'll let him go in peace.
All right, and why do you place this order in Mr. Hayes's EMR, his electrical medical records?
Because his CAT scan of the head findings of the diffuse brain edema, most likely he will have anoxic brain injury, means that he has more than 10 minutes deprivation of blood supply to his brain, and he will have a poor outcome. So in this case, it's not really recommended to do resuscitation again if his heart stops. So for this, I put this order in.
All right, and when you leave for the night, I should say, not the day, does this notify every other person who's involved with him that this is what his code status is?
Yes, ma'am.
All right, I am going to switch to what I've labeled as 3B regarding Beverly Scherzinger, and let me get to that record, sir. All right, and I'm going to go down. All right, and before I go anywhere, can you tell us which patient this is regarding. Hang on, let me share screen. Forgot that step. All right, and Dr. Hagers, can you tell us which patient this is regarding?
Yeah, it's Beverly Scherzinger.
And what's her date of birth, sir?
It's October 17th, 1953.
And what is her admit and discharge date, sir?
October 2nd, 2017, and the short date is October 9th, 2017.
All right, and I'm going to go down to page 20 for your sake to get through to where you're at. All right. And can you tell us what you're doing at this point with Ms. Scherzinger?
She, most likely she came on my shift, and I was a consulting, critical care consulting physician, and I saw her when she came to ICU.
All right, and I'm gonna scroll down for you. Can you tell us why she came into ICU?
She is 63-year-old lady. She came to ICU because she has some productive cough, and her PCP. She visited her PCP, but nothing been done. So she came to our Grove City ER, and they perform a CAT scan for chest, and they showed she has a cancer, most likely a cancer in her left lung, and she was. This is why she came to ICU. Her sodium was low. Her sodium hyponatremic. Hyponatremic means her sodium was low, and per our hospital policy, if any sodium less than 120 has to come to ICU, because these patients are prone to have seizures.
Okay.
So she came to us, to ICU.
All right. I'm gonna go down a little bit. And just kind of following along the same thing we did with Mr. Hayes, tell us about her general condition that you looked at that time.
My exam for her was general. She was reviewed all her vital signs. Her eyes were fine, mouth was fine, respiration was fine, cardiovascular was fine, GI was fine, neuro was fine. So yeah, so her exam was benign. Yeah.
Did you give her a diagnosis at that time?
Yes, her main diagnosis that brought her to ICU is acute hyponatremia, mean acute low sodium.
Okay. And what were you looking at as far as treatment at that point when she's in the ICU with you?
My main goal is to bring up her sodium to the safe range. So because of her new diagnosis of lung cancer or lung mass, so this is a condition called SIDH that cause low sodium. For this, I needed to restrict her fluids to bring up her sodium and follow blood work every 6 hours. And in the same time, I wanted to work up her cancer to see if it spread anywhere else. So I sent her for other CAT scan of her head, abdomen, and pelvis. And I consulted oncology team to follow on that.
All right. And I'm going to go forward to page 53. And I just want to talk very briefly about this order. Can you tell us what was ordered at this time for Ms. Scherzinger?
This order for severe pain, it's as needed order, and I order morphine 2 milligram IV push every 2 hours for severe pain scale. Yeah.
And IV push, what does that mean to us?
IV push means like it's a syringe, like maybe 10 cc or 5 cc syringe, and the nurse will, like, will get it from the vial and push it to the patient when patient requires pain control.
And do you remember, while you were treating Ms. Scherzinger, did those 2 milligrams help her pain?
No, I don't remember.
Okay, that's fair. All right. I'm going to switch to Mr. James Allen. Hold on just a minute. And this is what I've marked for identification as States Exhibit 8B. Dr. Haggard, can you identify the patient for us?
James G. Allen, his date of birth is 5/29/37.
And what was his admit and discharge date, sir?
He was admitted on May 24th, 2018. The discharge date is May 28th, 2018.
All right, now I'm going to go forward to page 5 and 6. Dr. Hagris, can you tell us what you're doing here? What is your involvement with Mr. Allen?
I was putting a vascular access. It's either a central line, it's a long IV access, go to the one of our main veins, and this will give us a good access to give him all kinds of medications. At the same time, if I need any blood work, or we can just take it from this line. Or I was putting an arterial line. Arterial line, it goes to one of our arteries here in the hand to just monitor his hemodynamics.
Okay.
So it's not clear here in this page which procedure I placed for him.
All right, let me go down and see if that clears it up.
Okay, so it's a central line.
Okay.
It's a central venous line, yes. So I placed a central venous line in the right internal jugular vein.
Any issues with that procedure?
No.
And what was Mr. Allen's diagnosis that he was in the ICU for at this point?
I can't tell from this document really. But here, it's here. Diagnosis septic shock. Yes, here. Septic shock. Septic shock means patient has severe infection that caused him to have a low blood pressure.
Okay.
In this case, the patient will need antibiotics, we need a medication to bring up his blood pressure. And in this case, I need to place a central line to infuse safely this medication.
Okay. All right, and I'm going to switch now to Sandra Castle.
She's Sandra M. Castle. Okay.
And what was her admit and discharge date, sir?
Admit was November 10th, 2018. Discharge date is November 13th, 2018.
All right, and I'm going to advance to page 7 for you. And can you tell us what your involvement with Ms. Castle is at this point?
I think I'm the one that I admitted her to ICU, or I saw her when she came to ICU, and I put the critical care consultation.
Okay. And why was she in the ICU with you?
She came because her husband found her unresponsive, and I'm sorry,
Sorry, I
could
went
you
past
scroll
it.
up a little bit here? And okay, and yeah, and she has a cardiac arrest, and her son started the CPR. EMS was called, and they took over, and she was in BFib arrest. So she was in cardiac arrest, and she got shocked by EMS, and they give her a medication called amiodarone, and she got intubated, and her pulse came back, and they started her on a pressor medication, Levofit. When she came to ICU, she was moving, but not purposeful. And I cooled her down in the ICU, and I did talk to her family in the waiting area and updated them about the plan of care.
Okay. And along the same lines as we've talked about with your other consultations, what did you find as far as her general vitals?
Well, I reviewed all her vital signs when she came to ICU, and her pupils were reactive, and I didn't see anything in her mouth or respiration. Could you scroll down, please?
Yes.
Otherwise, yeah, I didn't see any abnormal cardiovascular or, yeah.
And what was her general condition then as she was admitted to the ICU?
She was critical, in very critical condition.
Okay. I want to talk about, you indicated she was intubated. What does that mean to us?
This means the patient cannot maintain her own breathing. So she got a tube down her throat, and she's hooked to a ventilator to do the work for her.
And I'd note here, you actually use Versed and fentanyl together. Why would you use that medication at this point?
This is a very common practice to start this medication while the patient is intubated, because the tube itself is irritant. Okay, so and it will cause a gag and cough. So I need to keep the patient comfortable, and I want the patient to work with the machine. For this, he has to be under sedation.
And I'm going to go forward to page 73 first. And Dr. Husel, I want to talk about this order here, full resuscitation. What does that mean to us? Dr.
By the way,
Haggers.
I'm Dr. Haggers. Yes.
Sorry.
Yeah. Yeah. So full resuscitation means it's a full treatment. Patient will get a full treatment, and if his heart stops, I'm going to do a resuscitation, give him all kind of medication to bring him back.
Okay.
Yeah, Shannon, like I said, they're showing how we
Your
actually
orders.
do palliative care, and Dr. Husel didn't follow these procedures or rules. And that's to show he committed murder, that he didn't follow any rules and he did it on his own. I don't know if you heard me earlier, but that's my theory about why this guy's there. To show you how it should be done.
Dr. Hagris, I want to talk about this order here for fentanyl. Can you tell us about how much fentanyl and why you're ordering it at this point?
This is because she's intubated, so I need to keep her under sedation. So if she needs a breakthrough pain control, I'm providing her with 50 mic of IV push every 1 hour as needed.
Okay, so
And the rest score at this point was -1 to +1.
all right, so tell me what a RAS score is, because we haven't heard that
It's
one
called
before.
it's a Richmond agitation sedation score, and it goes up to +3 to -5, and this score like mainly we keep the patient +1 to -1, and this score the nurse will render every maybe 1 hour to be sure the patient will meet the score. And this score, what's the goal is just to keep the patient comfortable and synchronous with the vent, because I want the ventilator to work for the patient. So I want him to be on this like sweet spot, so he would be comfortable and the ventilator will work for him.
All right, and you ordered 50 micrograms IV push inject. Tell me how that's going to be administered so we understand this.
Well, I put the order in. The order will go to the pharmacy to verify it, and they will send it to the nurse. The nurse will get the vial, will take the medication and push it to the patient if the RAS score is still not maintained.
And this was something that would maintain them, is what you said, as far as patient while they're on the ventilator?
Yes, ma'am. Yeah.
Going on to the next page in this order, fentanyl additive 2,000 micrograms. Can you explain what that is to us?
This is an infusion medicine, and this is also a common practice. My practice is a patient has tube down his throat, he's intubated. I want to keep him in a good rest score, so support him. So I will start fentanyl infusion to be sure the rest score will be maintained like 24 hours. So I start him on I start her on fentanyl infusion. The range is 25 to 500 mics per hour. So they start 25 and they titrate up to achieve the RAS score. And the RAS score is the same here, -1 to +1.
25 to 500 an hour, so that's going to be for an entire hour time period?
Yes, ma'am. 25, we start 25, and the maximum is 500 mics per hour.
Is 500 mics per hour high?
Objection.
What would determine how much fentanyl that Ms. Castle will get each hour?
I'm sorry, say it again, repeat it, please.
No, it's not the same thing. Doctor, when you made this order.
Yes.
Okay,
I'm sorry, I can't hear. Can you?
I've got my mic off because of the echo. When you made this order, why did you put that amount of fentanyl to be distributed to her?
Well, it depends. We start 25 mics per hour. Then the nurse will assess the RAS score. And you can see here, it's a titration medicine. So she will titrate up till she gets the RAS score -1 to +1. And this is where the patient will stay on.
All right, Dr. Hagris, here, let's talk about this order also.
This is also a common practice is to start a sedation. So the patient, when the patient comes like, a critical ill patient, and he's intubated or she's intubated, I need to keep the patient on 2 infusion medicine, on analgesia and sedation. So analgesia will be provided with a fentanyl, and the sedation will be provided with Versed. Plus, I'm cooling the patient down. I'm putting the patient under a cooling blanket to bring down her temperature, and this is very discomforting. So I need to be sure that she gets enough sedation. So I started Versed infusion, which is 50. It's a 50 milligram on the bag of normoxidine. It's a 2 milligram per hour, and the RAS score is the same, -1 to +1.
So did I hear correctly, 2 milligrams per hour?
Yes, ma'am. Yeah. Yeah.
And you had just said this is very common when they're intubated. Can you explain that to me?
When patients intubated, I need the patient to be in a good, comfortable spot, and the machine will work for him. Plus, this patient also, I cooled this patient down. So her temperature, I'm going to drop her temperature to 34 Celsius. So, and this is very discomforting. So, I need to keep her under good sedation. So she will not shiver. She will not really be agitated. So, and this is a common practice in these cases. Yeah.
All right, and you said something that you said because the ventilator will work for her. What do you mean by that?
Well, I need to be sure the patient will be synchronous with the vent, because sometimes when the patient is not under enough sedation, the patient will cough, the patient will fight the vent, and the vent will keep alarming. So in this case, this means the patient needs more sedation. So in these cases, I need to keep the patient under enough sedation so the vent will work for the patient till I fix the problem in the patient.
Okay. All right, and Dr. Hagris, I'd like to talk to you about this order from midazolam, Versed. Can you tell us about this?
Yeah, this is for the breakthrough agitation, like the breakthrough pain for fentanyl. I put a Versed. It's a 2 milligram injection every 15 minutes if the patient needs it, and to get the RAS score under control. But this is not mainly for the RAS score. This is mainly for agitation.
Okay, explain that to me.
A patient gets agitated and she is coughing, she is fighting the vent. In these cases, we give this medication to keep the patient synchronous with the vent.
Okay, and here you're using 2 milligrams, I'm sorry?
2 milligram IV every 15 minutes, yes.
All right, and I want to switch over then to the last patient you were involved with, which would be Rebecca Walls. And Dr. Hagris, can you tell us who these records are regarding which patient?
That's Rebecca A. Walls, and her date of birth is July 7th, 1943. She was admitted on November 13th, 2018, and discharged on November 19th, 2018.
All right, I'm gonna move down. To page 2 here. Can you tell us what your involvement with is with Ms. Walls at this point?
She came to ICU in my shifts, and I saw her ICU and put a critical care consultation.
And why was she coming to see you at the ICU at this point, sir?
She came to ICU. She had a cardiac catheterization, and she had a complication with a groin hematoma. Patient was in PACU for 15 minutes with the pressure applied to the groin to stop the bleeding. And she came to ICU because her blood pressure dropped and she became altered. But in ICU, she was more arousable. She gave me all her answers, and I found also her carbon dioxide was high, so I placed her on BiPAP, and vascular team was consulted instead because of her because of a groin hematoma.
All right, hematoma, what is that to us lay people?
It's a blood collection under the skin.
And BiPAP, what is that?
BiPAP, it's a pressure mask. Okay, it applies two kinds of pressure. It's something like when sleep apnea when patients sleep on a CPAP machine. This is like this. It's a pressure mask, provide pressure and oxygen for the patient.
And as we've talked about with the others, what was her general condition then at that point in regards to her vitals?
Well, in my exam, I reviewed her vital signs. Everything seems to be normal except her extensive right groin hematoma, and it went down to it extended to her midline of her right leg. Otherwise, she was alert, oriented, time free. Yeah. So everything was benign except her right groin.
And as far as any other information that would be relevant or that you found relevant at that time?
No, CT, I sent it for,
Object. Hold on, Dr. Hagris.
The question
Okay.
is okay, but clearly you need to, let's rephrase the question.
Sure, absolutely, sir. Her general condition at that time, other than what you've told us, was there anything else that was important to you as the treating physician at that point?
Well, at this point, I wanted to send her for CAT scan just to be sure there's no bleeding in her abdomen, like behind, like something called retroperitoneal. It's a part of our abdomen. And at the same time, her pressure was still low. So I started her on IV pressor medication called Levofed. And I placed a central line for her, and I give her 1 unit of blood. So she was in fairly critical condition because she was in Levofed. She required blood transfusion, and I was looking for the CAT scan finding also. Yeah.
All right, and you've said the term pressors a few times. What is that to us?
Pressor, it's a medication when the patient has a low blood pressure. This medicine, what it does, it constricts our artery to bring up the blood pressure.
Okay.
The main agent that we use in ICU called Levofed, which is a norepinephrine.
Okay. I'm going to go forward to page 67. Okay, and in case, I don't know that I said this for the record, this is what's labeled States Exhibit 13C. I want to direct your attention at this time to the order in the middle of the page there, midazolam. Can you tell us about that?
I order Versed midazolam. It's not clear here how many milligram.
Okay.
It's IV push, but for some reason it doesn't tell us how many milligram was the order.
Okay, let me go forward then and see if we can get anything else. All right, so let's talk about the fentanyl. Can you tell us about that?
Yeah, I order here it's a 50 mic, but it doesn't specify how like frequent. Is it one time or what? It's not clear in this order, but I order 50 microgram of fentanyl.
Hang on just a second, Dr. Hagris. Maybe I can simplify this. Just a minute, Dr. Hagris.
Sure, take your time.
All right, just a few follow-up questions, Dr. Hagris. You indicated your shift. What days did you work at Mount Carmel West?
What days?
Correct. Or nights, I'm sorry.
What nights? So I work, me and Husel, we used to split the week. So I come and I work 4 nights. Then he will come to cover 3 nights. Then the week after, I come and cover 3 nights, and he will do 4 nights.
Okay. And were there specific nights you worked as far as days of the week, nights of the week?
Yeah, I remember I had specific nights, but I really don't. I don't remember the exact dates right now. I remember that we were alternating Saturday nights.
Okay.
But I don't remember. Yeah.
Okay, that's fair. When you were describing the BiPAP, you referred to CPAP. What is CPAP to us?
CPAP. CPAP is a machine. Patient has sleep apnea. He sleeps on to keep the pressure on oxygen. But the BiPAP is more. It gives more pressure. It gives 2 pressure, and this is what we use in the hospital.
Okay. Do you know what the CPOT is? CPOT.
Well, it's a pain scale, but it's more nursing business. You know, I don't use it really.
Okay. Dr. Hagris, we've seen how you've used the fentanyl over the course of, I think you called it titration, so many micrograms per hour, depending on the score. The RAS score was how you had it in those. Have you ever given one?
Okay, there's an objection. It's premature. Overruled for now. Finish the question.
1,000 micrograms of fentanyl as an IV push. And wait a second before you answer that.
Okay. Overruled. You
Okay.
can answer that question.
You can answer that question, Dr. Hagris.
No, ma'am, I did not.
Okay. No further questions, Your Honor. Dr. Hagris, we're going to have to do some logistics and switch the computers out so Mr.
Okay.
Baez can ask questions. So hang on a minute, okay?
Can I do my job?
I'm sorry, sir.
Okay. I need to give my court reporter a break. We've been going at it an hour and a half. Okay, so we're going to take 15 minutes. We'll get all organized. You can stretch your legs, walk around. get comfortable, get a
Okay.
cup of coffee, whatever you want. And then we'll be back
15
in
minutes?
15 minutes. Ladies and gentlemen, I'm going to
Thanks, sir.
send you on break for 15.
All rise.
Remember the admonitions. Hopefully we don't lose the contact because he just shut us off. Is there anything for the record, Ms. Swanson? Anything for the record? Well, let the jurors get out of here first.
Gotta clear the jury up before you talk about the record, Judge.
Anything for the record?
No, Your Honor.
Mr. Baez?
Jose, anything for the record?
Okay.
We're gonna figure this
We're
out.
in recess. You guys can get set up. Mr. Kirschman, do you need to see me? Okay.
Do you
Yes, sir.
guys have the Zoom link? That's probably where we have to start.
Sawyer, I know.
Yes.
I
All right,
got it
hang on a
right
second. I'm
early.
gonna get into my email.
I apologize.
what's
I don't
going
know why
on?
I want to call you Swanson.
That's okay. I think I worked at Stark County for 7 years, and about my 4th year in, somebody called and said, "Is there an S on the end of your last name?" I'm like, "It took you 4 years." All right, let me find the Zoom link. Oh, awesome. All right, well, that's not gonna help me. Let's see what I can do here. Forward. We're working on it. Okay. Yeah.
I need to set up my coaster.
Okay.
Hmm.
Move my water bottle for you.
All right. Sounds like we're just having a joke and a smoke right now. So, yeah, being obnoxious.
Meeting file help.
So we're on break right now. Do you guys have any questions about anything? You can throw them in chat. I am gonna sneak out of here for 1 minute. This guy will be that would be interesting. This will be an interesting one. What goes forward from here? Oh, chooka 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 choo. So, guys, sorry, I was just reading up on something. Yeah, did it keep you serving your guy? Actually, we got it all worked out. He had a very good excuse why he was not in court. He provided that to me, and I provided it to the court. So, everything's been fixed. Going till 1 a.m., that's absolute nonsense. Like, I mean, I know she's done that, but why? Why would you do that? Why would you do that? There's no point keeping a jury that late. I don't think so, at least. Um, I mean, I've been there till like 9 or 10 o'clock, but like I said, that is so. I mean, I hope that answers it. Like it. Hello, Teddy. Yeah, I don't know. 16 watching 5 likes. All your attention has to be on us. Yeah, Matthew, that's just going that late is a little bit obnoxious. Now, yeah, that's just a bit much. I mean, even me, I'd be like, yeah, I'm going home to sleep. Because I've been in some courthouses where the judge says you can't leave the building or you have to be within X amount of distance, driving time. Well, you get to like 10 o'clock. I'm like, I'm going home. Hmm. Sounds like Jose's going to be stepping up. The state has just finished, it looks like, or there's a break at least in their closing argument. So for Curtis Reeves. Mm. Let's see what else you guys are talking about right now. Yeah. Hey, Matthew, I've been in court before when phones ring. I've had my phone ring in court before. Um, yeah, Lori, and that's entirely up to the jury. But I mean, if they're going to 1 o'clock, they must have really been into it or almost there. But in Ohio, the judges will tell the jury like, "We'll go as late as you want," generally speaking. But at some point, the judge will send them home. That just going to late is kind of goofy. But yes, I've had my phone go off myself. I've been in court where the judge's phone goes off, and that's hilarious too. There was a judge once I was in front of where his phone went off, and he had made a big stink about it. I guess the week or two prior, and his phone went off in court, and fined himself. He found himself in contempt and fined himself like $50, And right after I was, we had a kind of a cattle call hearing where there were a bunch of cases being done at once. He immediately went down at lunch and paid his fine to the clerk. Let's see here. I'm sorry, guys. I was answering other crap. Yeah. Be right back. The defense is getting up. Don't bring in fines for contempt to the chat. That's okay. I've almost been held in contempt myself, so I would never bring that here. That would just be bad karma. Okay, so where are we at right now? Anybody who's wondering how things are going in Ukraine, things are not going that good right now for the Ukrainians. Kiev is having a bad day. Do, 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 do. Boom, 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 ba-dum, boom, ba-dum, boom. Do. Oh, and the defense is starting for Curtis Reeves. We'll switch over to that for a minute, guys. I'm sure that'll give us something to talk about.
In our laws, both nationally and here locally. A great wisdom. That wisdom in the law of self-defense starts with a term called perception. You're going to work with that term throughout your deliberations in this case. Because the law
Yes, this is defense
protects
closing.
that reasonable perception. Reasonable perception. You have to walk in the shoes of someone before you judge them. You've got to walk a mile. The law of self-defense requires us all to judge the reasonableness of that perception, not here in the comfort of a courtroom, in the protection of a courtroom with deputies that are armed to give us that security. The law of self-defense requires each and every one of us to stand in the shoes of Curtis Reeves, a 71-year-old man at the time of this incident, a decorated law enforcement officer who had countless and countless hours of training in the use of force, in the assessment of danger, and the risks that take place when we are faced with a dangerous encounter. Curtis Reeves, at the time of this incident, had more knowledge, more experience, more study in that area than anyone in this courtroom, and certainly anyone that was responsible for investigating his fate. Perception. The prosecution came up here. I think I counted, we're probably at 28 to 30. It doesn't matter. This doesn't matter. This doesn't matter. This doesn't matter. This doesn't matter. And by the way, this doesn't matter either. And this doesn't matter. And by the way, this doesn't matter either. Ladies and gentlemen of the jury, everything matters. Do not discount anything. Do not discount anything that we do and we say and we present, and do not discount anything that the prosecution presents either. Because it matters. We live in the greatest country in the world that considers our system of justice the very best. And the very best because we have to consider the evidence. We have to analyze the evidence and judge that evidence. And this very court, the judge, is going to instruct you on a great deal of rules that you can apply in this case. I'm going to ask you to thoroughly review every one of them. We're about to start doing that ourselves. I'm going to take you first through those rules, and then I'm going to take you through every piece of evidence that came before you in this case. And it does matter. Matt, your instruction.
That's powerful. I like that. That was good.
She is not guilty. The court's going to instruct you on an instruction called plea of not guilty, reasonable doubt, and burden of proof. It is the bedrock. It is the foundation.
Is she on a fucking
Of our
boat? It looks
system
like
of
she's
justice.
just going up and down and up and down. And
And one of the reasons that it's one of the
I don't
first
know how the
ones
fuck you can do
is that
that.
that's where you start.
Must have a strong core.
This is where we start, all of us, in administering justice in this very courtroom. And what does it tell us? What does the wisdom of this law tell us? It tells us that Mr. Reeves has entered a plea of not guilty. And it tells us that this means that you must, not can, you must presume or believe that he is innocent. That's how we start this trial. There's a reason for that. There's a reason for that. Because it's not Mr. Reeves' obligation to prove his innocence. It's the prosecution's obligation to prove not only the crimes alleged, but is to prove beyond and to the exclusion of every reasonable doubt that the defense of self-defense is not present. That's his burden. So we start with that presumption. And where does that presumption go? That presumption stays with the defendant as to each material allegation.
Put on this
At
clinic.
each stage of the trial. Unless
This is the shit that sticks with people.
Unless it has been overcome by the evidence to the exclusion of and beyond a reasonable doubt. Very powerful instructions for the protection of our liberties.
You know, Teddy, I'm thinking about that makes sense. I was just wondering how she kept on like bobbing and rocking.
Okay. Reasonable doubt. That's a word that, again, you're going to be instructed by your honor, that you're going to be considering in this particular case. And so, wherever the words reasonable doubt are used, reasonable doubt is not a mere possible doubt, a speculative doubt, an imaginary doubt, or a forced doubt. Such doubt must not influence you. However, on the other hand, if after carefully considering, comparing, and weighing all of the evidence, all of it, ours and theirs, there is not an abiding conviction of guilt, an abiding conviction of guilt. Or even if you have that conviction, but it is one which is not stable, but one which wavers and vacillates, then the charge is not proved beyond and to the exclusion of every reasonable doubt. That's your guidance in this case. And one that, no, we cannot say that doesn't matter. That is not our system of justice in America. Where do we look? Where do we look for that reasonable doubt to determine guilt or innocence? Where? It is to the evidence introduced at this trial and to it alone that you are to look for that proof, and to it alone that you are to look for that proof. Where can that reasonable doubt arise? From the evidence, conflict in the evidence, or lack of evidence. Now, the prosecution says, look, we had horrible law enforcement officers. It doesn't matter. It doesn't matter. I about fell out of my chair. It always matters in our system of justice. It always matters. If you have a reasonable doubt, you shall, not can, not possible, you shall find the defendant not guilty. Because it's their obligation and it matters. I need to blow it up on that last part. Thank you. If you have no reasonable doubt, then you shall find the defendant guilty. It goes both ways. Next one, man. Justifiable use of deadly force. This is an instruction that the court is going to give you, and you are going to be able to work with this instruction for a very important function in your decision. Of the state of Florida. And in looking at this instruction, the use of deadly force is justified if Curtis Reeves reasonably believed that the force was necessary. Remember what I told you from the very beginning? You don't judge a person until you have walked a mile in their shoes. That doesn't say you judge Mr. Reeves by what the prosecutor here has experienced in life. You only judge Mr. Reeves and you step in those shoes as a 71-year-old former decorated law enforcement officer that not once in his entire career fired his weapon in the line of duty, that was asked to start one of the most dangerous squads that you could have in a law enforcement department. An individual that traveled the entire country to learn those cues to prevent that danger from happening. In the law of self-defense, it doesn't tell you, get smacked first, get punched first, and then you can see what you can do. Because as their witnesses themselves have told you, law enforcement, medical examiner, you name it, one punch can cause great bodily harm, and one punch can cause death. You've got to stand in the shoes before you judge someone. What else was in those shoes? What else were in those shoes? You were in a theater, in a darkened time of that theater. Previews were playing loud. The distance between Mr. Reeves and Mr. Olson was extremely short. You remember in opening statement, Mr. Lawson said, "Oh, he was in that row way over there." Did they even give you any measurements here? Not a single measurement was given to you by the prosecution, because they want you to think that that particular distance was a row way over there where this was happening. But that doesn't work, because you've got to stand in the shoes of Mr. Reeves as he was seated there in that seat at very close range to Mr. Olson. When you're applying this very instruction, because Curtis Reeves reasonably believed that the force was necessary to prevent, circle it, prevent. You don't get a punch first and then you get the justifiable right.
Physician lounge. I think it's like for also a few hours with other physician. But before my ICU.
Sorry, guys. I wanted to go back to
Sorry, I had
Husel's
the
trial.
ICU orientation.
Sorry.
Okay, and Dr. Hagris, it was the Mount Carmel job, your first job out of medical school?
Stacy, yeah, everything said in
No,
closing,
sir.
they don't get to keep that. Those
did,
are just aids
3 years
by the
and a half
defense.
in Atrium Medical Center. I was inpatient hospitalist. Then I was promoted to be a medical director of the hospitalist group in Atrium Medical Center. Then I came to Mount Carmel.
Okay, so you had prior work experience after having your residency and all of your other training, correct?
This is going to be good, Cross.
I had what?
Other hospital experience?
Yes, sir.
Okay.
Yes.
And after,
Mr. Pius, you're getting away from the mic.
Sure.
And that's what's part of his problem.
Okay. Can you hear me okay here?
Yes,
Okay.
that's perfect.
If you can't hear me, please just raise your hand and I'll make sure I adjust. So, sir, after, I guess, these few hours of training, you were then placed to work in the evening shift at Mount Carmel, correct?
Correct.
And you're the only doctor there in charge of 30 beds, is that correct?
Yes.
Okay, but you work with a big team. Wouldn't that be fair to say?
Yeah, I used to have a resident in the beginning. I think in the first 4 years, I used to have a resident work with me overnight. And of course, I have the charge nurse and the nurses.
Okay, and the residence is basically a doctor in training, right?
Yes.
Okay, so you're kind of training this doctor on how to do things.
Yes, yeah. I was his, like, backup. If he needs anything, if he has any questions, if he wants me to supervise any procedure, I will be his attending doctor.
But as far as the medical decisions to be made, the buck stopped with you as it related to these 30 beds when you're on your shift, right?
Well, if the residents, like, there used to be two kind of patients come to ICU. A patient with insurance will go to a hospitalist, CIC, and this is where I will manage this patient. And patient without insurance will go to a mid-clinic resident, and he will make decisions. And if he has any questions, he will come to me. But also he was in the capacity to make decisions for these patients.
Okay, and when you said that was at the very beginning of your employment, was that before Dr. Husel was working there?
Yes, was before he came. He came August, and when I came, there was a resident always overnight, and this resident overnight stayed, I think, for the first 4 years of my employment.
And Dr. Hagris, you had different training. Your specialty was internal medicine, correct?
Correct.
So that would make you an internist?
Internist, yes. Hospitalist, yes.
And that is different than Dr. Husel's training, correct?
Dr. Husel, he has a fellowship in anesthesia critical care. So he got internal medicine, then he went to fellowship. So it's different. Yeah.
And you're aware that Dr. Husel was trained in anesthesiology, correct?
Correct.
Okay. So those are two completely different fields, right?
Not entirely, because the anesthesia, like in the anesthesia also, they will have internal medicine training, because to apply the anesthesia, you have to understand the physiology and pathology and all kinds of like diseases, so they can apply the anesthesia science. So it's related, but it's not different, no.
Well, I'm not saying that they don't overlap. What I'm saying
Yes.
is that they're completely different. So for example,
Objection, Your Honor, he's testifying.
I was about to ask it.
Well, I'll let you have the question. Go ahead.
So for example, an anesthesiologist has more training in the areas of sedation, correct?
Yes, in the OR, yes.
Okay.
It's most
And-
likely in the OR.
Okay, and that would involve drugs such as fentanyl.
Correct.
And it's fair to say that an anesthesiologist is more comfortable and has more experience working with a drug like fentanyl.
Okay.
Objection,
But
Your
in,
Honor.
Sustained. Let's do a little sidebar if you want.
I'm sorry, should I answer or
No,
not?
no, no,
You
hold
can't
on.
answer it. You want to do a sidebar?
Sure,
I know you're
sure.
dying to talk to me.
The judge stopped them. They got to talk a second. Is there a pecking order where the attorneys sit at their tables? Generally speaking, the more important you are, the closer you are to the middle of the courtroom. Violet, I think he's just trying to break the ice and make a little bit of a joke because he probably heard about how things were going. What was the other question I saw? Yeah, so Stacy, the document that he's highlighting and was drawing all over, they won't get, but he used the actual jury instructions, so they will get that. But anything you show in a closing argument is demonstrative and meant to just illustrate a point. It's not actual evidence, so they don't get to keep it. Number one. Number two, if I bring something up, charts or anything, or pictures or whatnot, well, I'm not giving my crap to the jurors, so. I missed it. I missed exactly what the judge said, but he's stopping him.
So taking apart the overlap, in medicine, there are different types of specialization. You would agree with that, correct?
Here we go. We're back in play.
Yes,
And your specialization is that of internal medicine, right?
correct.
And can you describe for us the differences between an anesthesiologist and that of a internist?
Well, internal medicine, it's a 3 year program that's it's specialized in every organ. Like, I had like 6 rotations of ICU in University of Maryland East Campus. I had a cardiac rotation, sorry. I had a GI rotation, neurology rotation, rheumatology rotation. So all kind of like topics in internal medicine. I had a rotation, also outpatient had rotation, and I had to have a board test to be board certified in internal medicine. Anesthesia, I had of course, interaction with anesthesiologists in my training, also in my work experience. So anesthesia, they are specialized in the operating room where they put the patient that he will go to surgery under sedation. They work with different kind of medication. They work with the surgical teams in different fields. And they also responsible for waking up the patient after surgery. And they are also responsible for the ventilator management during the surgery.
Okay, so to try and put this in simpler form, in a simpler form, and I don't want to, if I'm incorrect, please correct me, but to try and put this in a simpler form, an anesthesiologist is trained or has specialized training in management of pain. Is that correct?
No, I mean, like we need to add first, it's OR.
Okay.
I need just to be sure. It's in the operate. Anesthesia is this is my understanding, and this is what I have seen on anesthesiologists. They work mainly in the operating room with the surgical patients, managing different kind of medication plus ventilator management.
Okay, so they're not the ones actually doing the surgery. They're the ones there managing the medications while the surgery is going on, correct?
Correct. They are managing the sedation for patients. Yeah.
Okay. And there's a whole area of specialization dealing specifically with that area of medicine, right? And that's called anesthesiology.
I'm sorry. Could you rephrase the question?
Sure,
Because I...
sure. So there's a whole area of medicine called anesthesiology that specializes in that type of pain management, correct?
Well, see, you keep pressing on pain management. You see, anesthesia, it's not about pain management. This is my understanding. Pain management, there's a different fellowship for pain management. There is a different fellowship called palliative care for pain management. Anesthesia is primarily to manage the surgical patients in the operating room to keep the patient under sedation while the surgery is done and managing the ventilator. I have no knowledge that the anesthesia is connected to pain management. This connection, I'm not aware about this.
Okay, I think it was a poorly asked question because I didn't want to imply that it was limited to that. There's obviously other areas that an anesthesiologist does. Let me try this. Fair to say, Dr. Hagris, that equally trained doctors with the same exact backgrounds can have difference of opinions on various aspects of medicine, correct?
Yes.
Okay, and in fact, that's why many people get second opinions when it comes to doctors, right?
Correct.
Because one doctor may be more comfortable doing things one way, and another doctor may be comfortable doing things another way, correct?
Correct.
Now, in light of that, and then that also takes into consideration what we as lay people may be considering a good doctor versus someone that's not as skilled.
Objection.
I'll permit the question.
You can answer.
Do you understand the question?
Yes, I understand. Yeah. Well, it's in medical field, as you said, every doctor has its own, comfortable, level and comfortable medication that you use. And judging doctor by doctor, this is I don't think, this is fair.
And you don't think it's fair because each doctor's experiences are also different, right?
This is the good stuff. He's drawing it out.
Yes.
And that's because so much of medicine is patient specific, right?
Ooh, it's gonna catch him.
Yes.
He's on trap now. Can't escape.
In light of that, Dr. Hagris, when you got trained at Mount Carmel when you first started, were you trained in anything that goes on at the pharmacy?
Goes to what? Pharmacy?
Yes. Were you trained in anything having to do with the pharmacy?
No, sir. No.
Okay. Were you trained as to every single thing that a nurse does at Mount Carmel?
No.
Were you trained on the Pixis machine?
No.
Did you have access to the Pixis machine?
No.
So could you ever go up to the Pixis machine and put your fingerprint there and it would open up a drawer?
Well, I never tried. I never tried, so I think it won't work, no.
Okay.
Because the only two people, I'm sorry, the only two people I have seen going to the Pixis and get medication or put medication in is the nurses and pharmacists.
Okay. So when you, fair to say you had the same exact position as Dr. Husel, correct?
Yes, sir.
Okay. Now, you just work different nights, right?
Yes.
Okay. So, in light of this, you're familiar with how things work at Mount Carmel, correct? In the ICU.
Yes.
Okay. Now, having said that, when it relates to medications, you either give a verbal order or enter in a written order, correct?
Correct.
And as far as you know, the medication gets administered, right?
Yes.
And that essentially is the end of your involvement, unless it needs to be addressed later, correct?
Not really. I mean, it's like if I give any medicine, like for example, if I give a patient has high blood pressure and I order blood pressure medicine IV, and and I give this medicine, I put it in, I will follow up with the nurse to be sure that the goal is achieved. You know.
I
So
meant,
there's some follow up.
I apologize for the poorly asked question. I meant as far as it getting administered. So
Oh yeah, that's it.
that's it,
That's
right?
Yes.
So for example, you give as a doctor a order to a nurse. That nurse will either input the order if you didn't do it yourself. And then at that point, as it relates to up until the point where it gets given to the patient, you have no further involvement, right?
Correct.
Now, as far as you're aware, at this stage, if it's a medication, at this stage, it goes to pharmacy for approval, correct?
Yes.
Okay. And if pharmacy approves it, you have no idea. All you know is it gets administered, correct?
Yes.
Now, if you see that it's administered, is it your belief that pharmacy approved it?
Yes. In my practice, yes.
Okay. If it's not administered, and what would happen? If it's not, let me rephrase it. That's a poorly asked question. If it's rejected by the pharmacist, how are you made aware of this?
Well, the pharmacist will call me to ask me, like, you know, like, for example, if I bought an antibiotics and a patient has a kidney failure and the antibiotic dosage should be adjusted. So the pharmacist will call me and he will say, you know, I need to adjust this. Are you okay with that? And I said, okay, do it please, and put it under my name. And he will put it under my name and he will adjust the dose and he will send it to the nurse.
So I'm clear, so we're all clear. The only way you're ever notified if there's an issue with your dosage
Okay, you're away from the mic.
is if the pharmacy comes to you and talks to you, correct?
Well, he will call me. Yeah, most likely he will call me on my hospital phone and he will talk to me. Yes.
Okay. Now, in addition to that, but prior to going to pharmacy, if a nurse has an issue with your dose, he or she can also, he or she can also bring that to your attention, correct?
A nurse? Well, in my practice, I don't recall a nurse came to me and told me that I'm not comfortable with this dose. So, but they have the capacity to do that, you know, but I didn't have this experience.
That's what I'm asking. I'm speaking in general terms here. It's your understanding, sir, that the nurses, they're not just robots, right? They have their own independent medical judgment, correct?
Correct.
And
Correct.
that's a part of the process, right?
Yes.
So if a nurse took issue with any of your doses, they have the ability to, and it's your understanding, they have a duty to speak up, right?
Correct.
And at that point, the only way you're advised, if a nurse has an issue with any of your orders, is if she either speaks to you about it, correct?
Yes.
Or perhaps she goes to a manager, like a nurse manager or the charge nurse, and they speak to you about it, correct?
Yes.
And in fact, there are multiple ways that these things can be done, correct? And let me give you a couple of examples before you answer. One, they can speak to you directly. Two, they can go to the charge nurse. Three, they can go to the nurse manager. All of those are correct, right?
You just asked that.
Yes.
I was summing them up, Judge. And in addition to that, you talked about a voice report earlier in your direct examination, correct?
Yes.
That's
Yes.
another way you could discover whether someone has an issue with your doses, correct?
Yes, sir.
Okay. Are you ever notified any other way other than the pharmacist calling you that an order has been rejected by the pharmacy?
No, I mean, this is the only way, and the term rejected really, it's not clear in my ears, because I never had this before, but yeah, the pharmacists always call me. They always call me if they have any, like drug interaction. If they have any concern about anything, they will call me immediately.
And that's something as a doctor that you rely on, right? If there's some kind of drug interaction or an issue with the drug, that the pharmacist will tell you about it, right?
Yes, yes, sir.
Okay, and you rely on that daily for your job.
I'm sorry, could you get close to the mic?
Sure, and you rely on that daily for your job, to do your job correctly.
Yes, yes, yes.
Okay.
Pharmacy is very important, yeah.
Now, are you ever aware whether a medication is prospectively reviewed or retrospectively reviewed by the pharmacy?
In my practice, no.
Nobody comes and tells you this was prospectively reviewed, do they?
No, sir.
Nobody ever comes to tell you this is retrospectively reviewed, correct?
Correct.
And nobody ever comes to you and says this was simultaneously reviewed at the same time as it was administered.
No, sir. The only thing I get from the pharmacy, as I said, when I put the order and there's some, concern about dosage, antibiotic, kidney function, anything, they will call me and we'll discuss and we will adjust it and the order will be approved.
And that's not something you go actively looking to find out, is it?
Say it again. What do you mean?
Whether something is prospectively reviewed or retrospectively reviewed, that's not something that you go actively looking to find out, right?
No, I actually don't know even. It never happened in my practice, so I don't know how even to look for it. Yeah.
Okay, you wouldn't know where to look and know that, right?
Yeah. Yeah.
Okay, and it's not even a factor in your consideration. It's not something you do, right? It's not something you do at all in your job, is I guess the simple way of asking this.
I think there's some misconception right now. So let me clarify. So I put the order in. It's either verbal or in the system by myself. If there's any concern from the pharmacist, he will call me. He will call me and we'll discuss and we'll adjust it and it will go through. That's it. And the medicine will be sent to the nurse and she will give it to the patient. So I never had any in my practice about any of these prospective or respective review. So I have no knowledge about this.
Okay. Now, having said that, sir, you're also not aware, or let me strike that. Do you ever pay attention as to how the nurse actually retrieves the medication? Do you ever get involved in that
No, sir.
process? I'm sorry?
No,
Okay.
no.
Do you ever find out whether the nurse received the medication after it was approved or before it was approved?
Well, in my practice, I put the order in, and the only time that I put the order in after the medication was given in emergency. So a patient has a cardiac arrest, and there's something called a code blue card. We pulled it and we break it and we give the medication, give it to the patient. And after doing the resuscitation, I go and I ask which medication was given, and I go to the system and I put the epinephrine, atropine, whatever was given to the patient. So this comes to my inbox as a co-sign order. So I verify the order, then sign it.
Okay. Let me see if I can ask this question a little bit better. Are you familiar with the phrase scan to order?
Scanned order?
Scan to order.
Yeah, this is a nursing business. I'm not really, I don't have the best knowledge about it.
Right. So let me give you an example of what I'm referring to. This one. Let's bring up this one first. Now you recall giving discussions about Rebecca Walls. Do you recall that? I'm showing you at this time what is Exhibit 13, page 343.
Take it out.
Okay.
You gotta enlarge that. You've got just a short screen there.
Yeah.
Expand it out.
Okay.
You can also make the screen, the frame bigger.
That's what I'm trying to do.
Top, middle.
Okay, let's go down to the bottom. Now, well, actually, let's stop here. You would go back up to the top. Sorry. Okay, you would agree that this is the medication order for Rebecca Walls? Do you see that?
Yes, sir.
Okay, and you were asked about her during direct examination, right?
Yes.
And you were shown various medical records about Rebecca Walls?
Yes.
Okay, now I want to direct your attention to the bottom of the screen, specifically the order for midazolam.
Okay.
Can we
Could you
scroll that
scroll
down?
it down?
Yeah, he's going to scroll down for you, all the way down. There
Thank
you go. Okay. Now, taking a look at this order, this is an order you gave, right?
Yes.
And in this order, the date is November 16th, 2018. Do you see that?
Yes.
And midazolam is a controlled substance. What is it? What is midazolam?
Yes. I'm sorry?
What is midazolam?
It's a benzodiazepine. It's a sedative medicine.
Okay, it's also called Versed, right?
Yes.
Okay, and you gave this order at this specific time, and if we could scroll up a little bit more. No, I'm sorry, scroll down. Okay, and in here, do you see whether pharmacy approved it?
No, I don't see the pharmacy. Do you see? I mean, no.
And do you see if it ever went to pharmacy?
I'm sorry?
You see, does it indicate whether it actually ever went to pharmacy, whether they even saw this medication?
No, this medicine, it's 4 milligram of midazolam. This medicine, when I use it for emergent intubation. So this was an emergency for intubation for Miss Wallace. And for this, it was given and placed and co-signed with me after giving the patient.
I understand that. But my question to you, sir, is on this record, and if you look down at the printed date and time, it was printed out December 6, 2018. Do you see
Yes.
that there? Okay.
Yes.
Do you have any indication by looking at this right now whether it actually ever went to the pharmacy at all?
No, I don't see the pharmacy name in it.
Okay. And if you look at this, you have no knowledge as to whether this controlled substance was ever reviewed at any given time, even after it was administered, correct?
Yeah, I don't see anything in the review information part, yeah.
Are you familiar that this is what's called a scan to order?
I'm not sure about this term really. It's kind of like a nursing, but I heard it, but I don't have full knowledge. But I want to clarify this order when I put it in. This means it's emergency intubation.
I understand. Mike, so in light of this, sir, you're not aware
I'm sorry?
of how, I said in light of this, you're not aware of how a nurse actually enters in the order, even in cases of emergencies, right?
Well, I will verify it, yeah, initially I won't, but after I go back to the EMR, it will come to my inbox and I will see all these orders and I will verify it. And if I don't feel comfortable with any of these orders, I can reject it. So you can see I co-sign this, yeah.
I understand, Dr. Hagris. What I'm asking you is about the pharmacy. Here, and correct me if I'm wrong, here you gave an order in an emergency situation. The nurse obtained the medications and gave it, and there is no indication to you whatsoever that the pharmacy ever saw this controlled substance order, correct?
Correct.
Okay. Now, I'd like to show you Exhibit 12, page 325.
Candace, he's an internal medicine doctor at the hospital, same hospital. Yes, in the ICU, correct.
And I want to draw your attention to the top so we know who we're talking about. This
Sandra
is
Castle?
patient Sandra Castle. Do you see that?
Yes, sir.
And you were asked questions, quite a few questions about her in direct examination, right?
Yes.
And you were shown various medical records about Ms. Castle during direct examination, correct?
Yes.
Okay. Just for curiosity, were you given advance given these records in advance to review before your testimony today?
Yes.
Okay, so the prosecutor told you which records she was going to ask you questions about?
They gave me the information that I got involved, and they advised me to review these records.
Okay, so they asked you to do this before coming today, correct? Or before logging on today, I should say.
We did it, our lawyer and from the hospital, the one that sent it to me, and I had to interview with a prosecutor. And the hospital lawyer sent it these record to me, plus he sent it also the Columbus interview file to me.
That
And
drug
he asked
order that
me
I
to-
just showed you, did they review that with you?
I'm sorry, say it again?
The drug order that I just showed you that did not go to pharmacy, did they review that with you?
I don't think so.
Okay, now I want to show you this one. We already saw that it was Sandra Castle, right? You want to look at that again, or you're comfortable with that?
I'm okay, yeah.
Okay, let's scroll down. I'd like to draw your attention to this order for fentanyl. You are the ordering physician on this one, right?
Correct.
And did you enter the order or a nurse entered it?
I ordered this.
Okay, this was
100
a
mics.
verbal order that was co-signed by you?
Let's see, oh, yes, I can see right now. Yes, yeah, it's a verbal order by Nurse Matt and co-signed later on by me.
Okay, so this nurse, I guess Matthew Mislewiak, I know I just butchered that.
Yes.
Yes, you got it? Okay. Do you show, and obviously fentanyl is a controlled substance, right?
Yes.
Do you show that this was ever reviewed by the pharmacy?
I don't see this in this paper.
Did anyone ever bring to your attention that this order for fentanyl was not reviewed by the pharmacy?
No.
In preparation for your testimony today, did the prosecutors ever bring to your attention that this order for fentanyl was never reviewed by the pharmacy?
Not to my recollection, no, I don't recall that, yeah.
Is it something that you would ever go looking for during the course of your duties as to whether this was approved by the pharmacy?
No, my responsibility is to take care of the patient, put the orders, co-sign my orders, and discuss it. Yeah, like that's it. I don't review anything with the pharmacy after giving the patient medication.
Now, it's your understanding, as a doctor, an ICU doctor employed at Mount Carmel, that the pharmacy is going to review all of the orders for controlled substances that you give, correct?
I have no knowledge how the pharmacy works.
No, I'm not asking you that.
Actually,
I'm asking you specifically, it's your understanding that when you give an order for a controlled substance, that it's going to be reviewed by the pharmacy, right?
No, sir, I have no idea about this. I don't have an understanding. I don't have the knowledge that the pharmacy will review everything.
I don't think you're understanding my question. Let me try and rephrase it because it might be poorly asked. You believe when you give an order, it's your understanding and belief that when you give an order that the pharmacy for a controlled substance like fentanyl, that the pharmacy is going to review it, right? You rely on that.
Your Honor, I'm going to object. He's answered this question.
He has answered the question earlier in your cross.
Earlier, yeah.
Yeah.
Having seen this, sir, does this surprise you that this fentanyl order was not reviewed by the pharmacy?
Well, I need to clarify something. This is not really my knowledge or job to look for a pharmacy reviewed or not reviewed my orders. So you're asking about something it's really not in my experience, not in my knowledge. So I have no comment about this really.
I completely understand, and there's nobody arguing with that here. My question, sir, is does it surprise you that you're ordering controlled substances that are never being reviewed by the pharmacy? Does that come as a surprise to you?
Objection.
Sustained.
He hasn't answered that.
I know he has. It's not about that.
Okay.
It's about our earlier discussion over here.
Understood, understood. Dr. Hagris, okay. I think we get this point. I wanna move on for a couple other things if I can. Dr. Hagris, the prosecutor during direct examination went over a series of questions for you in relations to some of the medications that you ordered in these patients. Do you recall those questions?
Yes, sir.
Okay.
Okay.
And
you got away from the mic. You notice he was trying to get closer.
Sure. And all of the times that you gave these medications, they were while the patient was alive, correct? And not actively dying, I should say. Correct?
Well, I did a palliative withdrawal, so a patient is actively dying. I already put orders for them.
Let me see if I can clear this up. The questions that you were asked about Sandra Castle, they were not during the palliative withdrawal process of this patient, correct?
Yes. Yes,
They
sir.
were earlier in this patient's care,
Yeah.
right?
Correct.
Okay. And you would agree palliative care is different than that the normal care of while you're trying to keep the patient alive, right?
Sure. Yes.
Okay. In fact, you were at this point executing life-saving measures. You're trying to keep them alive. You're trying to make them better, right?
Correct.
Okay, so that is different than when the family decides that they want to withdraw care and take them off of the ventilator, correct?
Correct.
And in fact, it's fair to say that pain management in the living is different than pain management in the dying. Wouldn't you agree with that?
Well, pain management, I don't think it's, pain management, I use it only when the patient is alive, when I'm trying to keep the patient alive. Pain management, I don't think it's been used for in palliative withdrawal. What we use is comfort care. The term that I use in my practice is comfort care in palliative withdrawal.
That's a term you use, but in essence, when you're withdrawing someone from the ventilator, you don't want them in pain, do you?
Yeah, we do. I do a comfort care, but pain management, this term is used in the medical field in a living patient, but not in palliative withdrawal.
So my question, getting back to my original questions, all of the questions that you were asked about your medications as it related to Sandra Castle were not that dealing with palliative withdrawal, right?
Correct. Correct.
Okay. And then in addition to that, Rebecca Walls, the same thing. They were not in the context of palliative withdrawal, right?
Correct.
Okay. And when it dealt with Ryan Hayes, that was not in the context of palliative withdrawal, correct?
Correct.
And when it
Okay,
dealt with,
hold on, Mr. Bias. Ladies and gentlemen of the jury, it's getting to be lunch hour. If we come back at 1, does anybody have an objection to that? We usually go 1:30, but I've got him and I don't know how many time zones away. Would that be fine with you guys?
Yes.
Okay, why don't we break until 1? Okay, you got an hour off. I
Okay.
hope you're not gonna go to bed on me,
No,
okay?
no.
We'll be
No.
back in an hour. David?
All rise.
Okay, so we'll come back at, what time right now in US is?
It's 12 o'clock noon our time.
Okay, so it's 1
So we're
o'clock.
coming
We'll come
back
back at
at
1 o'clock.
1, so an hour from whatever time you're at now.
Sounds good. Okay,
Okay.
sir. Thank you.
I don't know how many time zones it is. You guys have a great lunch.
Thank you. Thank you.
So they're breaking for lunch now. Actively dying means like they're in the process of dying. I mean,
I
that's
figured you were about ready to transition. So-
Judge, I have no problem. Thank you.
Okay,
Appreciate it.
anything for the record?
so.
Miss Sawyer, anything for the record? Anything for the record?
Nothing.
Okay, we're down.
Thank you.
I saw Miss Roberts in the back. Did she go?
So I think that was interesting. That was a very great way of showing how things are done.
I figured she was
Wait,
here to yell
no,
at me.
Let's do
Oh my
lunch.
god, I let me hear the judge talk. You know, Violet, you're correct. I'm sorry, Little Miss, you're correct. But you know what? That's not standard. Violet, yeah, you don't have to worry about long-term damage, but if I have 5 more minutes to live, do you have any right to take those 5 minutes from me? And that's the argument here. Was he following the rules or was he actively killing people? And I don't think we can tell right now, based upon these witnesses from the state. He just may have not been following the rules and may have been doing things improperly, but is that intent to kill? I don't think so yet. So we can go back to Curtis Reeves and see if Dr. Marblebout is giving his rebuttal.
That's too much.
When Mesmer ordered stat, didn't they go through the pharmacy? Yeah, the pharmacy still orders stuff, but that's once again he's just pointing out nobody had a problem till yeah, exactly. Well, we'll miss. You know, yes, those 5 minutes could be spent that way, but his point is this is just why didn't they go to the pharmacy? It's has he done anything wrong? Has he broken the rules? No. If he hasn't broken the rules and he's doing things that were allowed, how do you establish he has intent to kill? What do I think? Jose Baez is doing great. I don't know if that's just because he happened to see this, but I'd like to think most attorneys could come up with this game plan. But he's doing really good. He's coming after these people, and he's he went after the cop in a vicious way, but you got to do that. With these guys, he's just questioning how they do stuff. Yeah, and I actually it's lunchtime, so I might take a break for a couple minutes, you guys. You can hang out amongst yourselves, but just I'm gonna work on a couple things, and as much as I like to hear myself talk, I'm gonna take a break. So I'll be back in a couple of minutes. the numbers dropped. We went from like 13 to 9. Thought you were gonna tell me there were like 1 million people. Hey, you know what, Critter? I'll put on Reeves for now. Just give me 1 second. Hold on here. Yeah, but they'll be back out of sidebar quickly, hopefully.
Incredibly simple to get. You can.
Remember, he told you part of the training that he had received at Bush Entertainment is that, hey,
There you go.
someone's having a problem with a patron. Don't deal with it yourself. You go and get a manager who has the authority to deal with that particular problem, and let the management take care of it. He thinks that's instigation. So I guess everyone at Busch Gardens are instigating because they go and tell management about an unruly individual at their amusement park. It's a darkened theater. Can I tell you how dark it was? Unfortunately, we can't. Whose fault is that? Whose fault is it that we can't tell how dark that theater was? You think Detective Proctor called Rick Escobar on his cell phone and say, hey, Rick, come on over, man. We got a shooting over here. I want you to try to preserve whatever you want to preserve. Now you can call Rick Escobar. Oh, Public Defender's Office. You know their number. Think that happened? In our criminal justice system, we rely on law enforcement to do things right. Because it matters. Because if they don't do things right, if they don't preserve evidence, the disadvantage that we face is insurmountable. I think Victor Smith told you, yeah, you're right, Rick, we preserve it not only for the prosecution, but we have to preserve it for the defense as well. And he's telling me over here it doesn't matter. Yeah, got a crappy investigative team out there, Rick. No problem. It doesn't matter. Just listen to me. Listen to him. That's what he's telling you. Just listen to me. Because all that doesn't matter. We'll get into Dr. Knox a little bit. He was an expert in the field of crime scene reconstruction. That's what he teaches. Not only in Jacksonville, but throughout the country. Law enforcement officers from all over. He told you the dangers of not getting it right. He told you the dangers of missing those pieces of evidence that can shout out the truth in a criminal investigation. It doesn't matter to the prosecution because they're not being accused. That's why it doesn't matter. But for anyone that's accused, oh, ladies and gentlemen of the jury, it matters. And so Curtis leaves that darkened room, whatever darkened it was, and goes down the road and goes to the main. You're going to load it, see that again. You'll have it in your deliberation room. You have a computer, a defense computer and a prosecution computer. You'll be able to look at all the videos and analyze all of that. And I encourage you to please do that. Because it matters. And so you'll see when he was talking to the manager, he was calm, he was polite, he was resting there on the counter. Remember Michelle Simpson was there? And what did Michelle tell you? Kevin looked over there, there was no signs of any aggravation or hatred or being mad. Because Curtis Reeves has dealt with these situations countless times before. What did he tell you? He's a mouthy guy. And his perception at that point in time is that's what it was. He was a mouthy guy that did the manager take care of things, and everybody can enjoy the experience again. There's one very important critical piece of evidence that you've seen in the videos. And that is he leaves the counter, tells the manager exactly where he's at, and pointing, I'm up at the very top middle. He comes back, and the first thing that Curtis does when he comes back is what? He grabs the bag of popcorn from video. It's in the video. That's the first thing he does. Do we think, does the evidence show that when he comes back, he wants to have any problems with anybody? He wouldn't be grabbing a bag of popcorn, I can tell you that. Because in his training, as he's told me, if he's about to get into something with someone, he better have both of his hands available. That slaps you right in the face. He grabs the popcorn from his wife and he sits down. It is at this time that there's that conversation by Mr. Olson where he is irate over the fact that Curtis has turned him in. And you got that from Mr. Cummings. You got that from Jane Roy. You got that from Curtis Reeves. This guy is upset that Curtis had gone and told on him with Benjamin. And so the only thing that Curtis does is say, look, I see you turned your phone down. We've never gone to tell management. And I see that you were going to put your phone on. That he calls instigating. As human beings in this community, we can't have that kind of conversation. If we can't, God help us all. And so at that moment, he jumps up, that being Mr. Olson, and turns around, and the profanities and the attack occur. Well, one thing I can tell you is, thank God for that video. I have no idea why he thinks the video is good for him, but thank God that we have that video. As bad as it is, as limited as it is, because it only records on row A, you'll be able to see that and analyze it and do everything that you need to do. It's supposed to be recording the scene of bistro. Thank God we got at least a glimmer of a section in that camera that captured row A. I wish it would have captured row B. Had it captured row B, we wouldn't be here. And what do we see? Somehow, the prosecution tells you that the first attack is a fabrication. We're going to see the videos in just a few seconds. That first attack, Mr. Olson, is clearly, half his body is in row A. And coincidentally, while his body is in row A, we see this either reflective or illuminating light. Do you recall what Mr. Koenig said? It was 6 pixels. Rectangle. Senator, can I see the cell phone? Please. Rectangle. Not square, not round. Rectangle, 6 pixels. Now, could we prove to you all that the illuminating or the reflective light that we're able to see as you see that body coming over onto row A, can we tell you for certain that this is what it is and that it is not Curtis's shoes? We tried. We spent a lot of money, experts flying from all over to get to that cop theater to try to prove with a cell phone in our hands and the actual shoe to try to determine what was that light source. And through no fault of the defense, and through all the fault of the state of Florida, we couldn't do it. Because the cop theater was pretty savvy. They had come in, taken all the hard drives in the middle of the night, on the night of the incident, from the cop theater with a patrolman, I don't know what he was, with a patrolman there, cordon off Mr. Sillis. My name is Mr. Sillis. I'm here to come get some evidence. Sure, come on in. Go upstairs, take all the evidence. Cop theater flying someone down from Alabama. Here, sir, take it back to Alabama. And within 60 days, not only had they taken the hard drives, remember Mr. Peck, what he said, they had dismantled and taken the entire surveillance system. So when we arrived at the cop theater in the middle of the night, 2 or 3 o'clock in the morning, Mr. Koenig told you, we couldn't do anything. It was a total waste of time because the responsibility of preserving that evidence was there the evening of January 13, 2014. I will tell you that they had, and you heard the testimony, they had Detective Husel, they had Detective Papanella, they had Detective Lindsay that had just gone briefly to the hospital. The 3 guys that had started the most respected unit in the Pasco County Sheriff's Office, the cyber crime unit, right there to do everything that we were prevented to do in that theater. They could have done it right there. And for one reason and one reason only, it didn't happen. Because Detective Smith now was assigned as the lead crime scene detective, prestigious position. And he decided that no, nobody was going to do anything. He was going to do it all. Remember, it was the second time ever handling a crime scene investigation on a homicide case. Detective Smith had not even taken the mandatory homicide course. He told you himself. No, hadn't taken that yet. And who was his shadow partner? Detective Proctor was the person that was supposed to teach Detective Smith. Now, if that's not the blind leading the blind, I don't know what is. Detective Proctor was cross-examined by me. And he had to admit from this very stand, he didn't want to. How long did it take him to admit? It was radio silence. Detective Proctor, you were not equipped with the knowledge. Detective Proctor, you were not equipped with the knowledge to handle a self-defense case. Because you, Detective Proctor, had only handled one before. And then there was that radio silence. And he finally had to admit, yes, Mr. Husel, I didn't have the experience. It took Detective Proctor 8 years to admit that he was not equipped to handle this case. Let's think of it. It doesn't matter. It doesn't matter. Could Detective Proctor have told Sergeant Sessa, hey, Sarge, I know I wasn't supposed to be assigned to this from the very beginning, Detective Soto was. But I don't have the knowledge. He waits 8 years. Yet before the ladies and gentlemen of the jury, their first degree.
Objection, improper argument.
Suspend.
It matters. We're going to go through the next very important part, because the first attack is as vivid as it can be in that video. Now, you remember, you heard testimony that both sides had the FBI. I don't know where their FBI guy is, but my
Objection, improper argument.
You heard from my FBI guy. Of course, they complained about him as well, that he was costing money. We brought you one of the leading experts in the country in video surveillance, analysis, and enhancement. Mr. Koenig has worked on the most important cases ever in this country. Fortunately, he lives right over here in Pinellas Park now. And what did Mr. Koenig do for us in those videos? He told you about a concept that is very, very important. It's called interpolation, you remember. And then when you're doing forensics, you've got to make sure that if you're going to enlarge or enhance that video in any way, it's got to be done a certain way. And that's called the pixelation of nearest neighbor. Because if you don't do it that way, there'll be problems. It's not forensically correct. And he told you what happens to big screens when we put things on. And that particular film and video have not been processed correctly with nearest neighbor. Because we don't know what's in the brains of this thing, he told you. We don't know what the algorithms are to make something that's being presented on this screen bigger. Remember we talked about the number of pixels, and through interpolation you could have 76,000 pixels, but if it's improperly interpolated, you can have 6 million, 12 million pixels that were never in that particular film and video to begin with. And guess what? You don't know what they're doing with it because it's proprietary. They don't want to release the secret so that a forensic expert can analyze it and make sure that what you're getting is truly forensically correct.
Objection, improper characterization of the testimony.
And so what happens? First attack takes place. We brought you that video. We're going to see it in a few minutes. We actually put circles around the two particular areas of focus. The reason that Mr. Koenig did that because he wants our eyes to be focused on that. We did it both ways. We did it without the circles. We did it with the circles. We did it at 200% magnification. We did it at 400% magnification. But he told you one thing that was important. Forensically, it was accurate. We're not putting any pixels that weren't there to begin. And so you're able to see at 25% playback, 50% playback, 200% magnification, 400% magnification. That was a monumental task. So that you would see the truth. Because when you see that archaic video, remember he told you it was worse than the quality of the first TVs that came out in America. When you see that video in a raw form, that first attack happens so quickly that you're not able to focus on it. Obviously, when we're in a court of law, we want you to focus on everything because it matters. Because it matters. Curtis Reeves, with years of his experience, was being attacked. You know, the prosecution came up here and said, if the phone was thrown, remember the left hand? You see how I just picked up this phone, right? The left hand. What hand was Mr. Olson holding the phone in as he was scrolling? Wasn't my witness. It was his wife who said Chad had his phone in his left hand and he was scrolling. He was scrolling. So phone in the left hand. When you see that first attack, that's exactly what happens. What does Ms. Turner tell you? Does Ms. Turner tell you that the phone's in the right hand? Or does Ms. Turner tell you that whatever object she saw, whether it was a thermos or a mug in a darkened theater, was being flipped or thrown with which hand? The hand that Chad Olson carried his phone. Now somehow, the prosecution wants you to think that somehow it magically got from Mr. Olson's hand, left hand, and somehow it got in between Curtis Reeves' legs by pure magic. Did they have anybody, forensically or otherwise, come here and tell you that it just floated in the air just out of mystery and it landed in between Mr. Reeves' legs? Take a look at a very important aspect of this video, that first attack. You'll see the body going over, and you'll see a light. At that same time, you see a light. Now, let's talk about that. Remember, we wanted to tell you here today, whether it was a phone or the shoe. We were not allowed to do that through their own fault, not ours. Could it have been the phone, that light that you saw? It could be. Could it be the reflection of his shoes? Of course. Unfortunately, in this case, to make matters worse, because they didn't preserve things as they should have, we've got a shoe that reflects as well. I would have loved Curtis to have sandals that were not reflective. Trust me. But now we've got this particular issue. It doesn't matter whether it was the phone or the shoes. This is the only thing that doesn't matter, because it's clear that that phone was in between Mr. Reeves' legs. Immediately, was seen by Mr. Hamilton after the shot was fired. Now, let me point out something else. If you say, okay, it's not the phone. And if you say that it's Curtis crossing his legs, it could very well be. Why was that crossed leg at that very moment moving in order to show the reflective characters of that shoe? Why? Why? Because Mr. Olson, you can see, is coming over the back of his seat towards Curtis. You know, the real problem with the phone issue, the reason that we went there at 2 o'clock in the morning, is that you have camera 11 and camera 12, right? There's a screen of the theater, camera 11, camera 12. These cameras, one camera is recording, the other camera is not recording. There's no rhyme and reason. It is the dinosaur of dinosaurs as far as surveillance system is concerned. You think to yourself, cop theater? Are you kidding me? But this is the problem. If the phone is not illuminated at that time, for whatever reason, it's a darkened theater. Are you going to get
Theater.
Are you going to capture that illumination if it's not? This is black. Same thing here. If the phone is being thrown, depending upon all the positions that a phone can be thrown, and that light is not on, are you going to capture the illumination? Six pixels was of interest to us. 6 pixels. We couldn't do what Mr. Knox and Mr. Koenig wanted to do, is to bring that evidence to you. For one reason and only one reason. Law enforcement failed to do their job. And so you'll see that there's about 8 seconds between the first attack and what I call the second attack, the popcorn incident. And remember, we had Mr. Knox, we had quite a few witnesses, and Mr. Koenig tell you that what someone is experiencing in that particular chair cannot be captured, that perception cannot be captured exactly from a camera that's 35 feet up in the air. Now, if the camera was right there, to see what you were seeing, to witness what you were seeing, that would be wonderful. We don't have that. And remember, whose perception is it? In whose shoes do we need to step in? The shoes of Curtis Reeves. It was he that was experiencing the attack. It was he that was feeling that particular item hit him on the head. Mr. Reeves, can I have your glasses? Let's hope that I do as well as I did before. It's old man glasses. They move everywhere. I'm not, the arms, the center, you name it. Everywhere. You think that they even looked at this forensically? You think they even used it in their attempted recreation? No, because they didn't have a recreation. We don't even have measurements from them. And does that particular area, something hits that particular area of the glasses, will it hit your eyelid? Something hits that area with some force. Will it cause some injuries to your eyelid? And the prosecutors picked this up. You don't want to touch it too much. I'm touching it. I want you to know the flexibility. You all grabbed it and did everything, legs, arms, whatever you want to do with it. Curtis Reeves was hit with a phone. That's without doubt. His own medical expert, his own medical examiner, sat there and said, you can throw a phone at somebody and not have any evidence that it was thrown and hit the face. He said that
Objection,
right up there.
improper characterization of the evidence.
There's so many variables. There's so many variables. Just because you throw a phone at somebody that hits them in the head doesn't mean that it's going to split their head open. Because we don't know what the force is. We don't know if it hit something before it hit the head. There's a gazillion variables that you have to consider. But we know this. They didn't even think of this. And remember, Detective Conan telling you that he told the tech, forget her name because she didn't have a major part, but let me see if I can quickly find it. Susan Miller. Remember Susan Miller? Koenig tells you, I told Miss Miller that she needed to take a picture of Curtis Reeves' injury to the left side of his face. Susan Miller told you, oh, absolutely not. That was an injury that I saw. Nobody told me that. And I documented it because that's my job as a forensic investigator to do that. And you've got the picture. It's their picture. And you will see that Curtis does have a red mark. Of course, now they had to figure out, oh, well, he rubbed that area. And so now he's fabricating that he was hit with a phone, even though the phone is in between his legs. Sorry, Curtis. That second attack, what are we seeing from seat 9A? If we were in seat 9A, what would we be seeing? We'd be seeing those hands coming at you. That's what we would be seeing if we were in seat 9A. That is what Curtis Reeves would be seeing. Curtis told you that after that first attack, his glasses were a bit askew. Now, you've seen those glasses. If it was my glasses, probably be, because they're so
Objection,
stiff.
improper argument.
My glasses would be stiff.
Objection, still the same argument. Doesn't matter what Mr. Escobar's glasses can do.
Mr. Reeves' glasses are flexible. And so he's seeing those arms coming at him. He told you before that situation, I knew that I had to retrieve my firearm because this guy was coming at him. And Mr. Olson's very wife was trying to hold him back and couldn't. I want you to think about that. Here's Mrs. Olson. Her husband has got to be somewhere either directly in front of her, whether she's seated halfway or totally up, or to the right of her. She's using her left arm to hold him back. Now, that's pretty awkward if he was here, but not so awkward if he was right in front. Why would Mrs. Olson have to hold because of it. Because she knows his violent tendencies.
Your Honor, it is completely improper and evidence that is not before this court.
Let me talk some over here. It's a screen in my way, that's why I'm sitting in by the jury so I can see the jury. Ladies and gentlemen of the jury, you'll disregard the last statements made by counsel.
So tell me, what does the evidence show as to why Mrs. Olson had to place her hand at or around Mr. Olson's chest? What was she trying to prevent? On his chest. Not, hey dear, calm down. Not, hey dear, calm down. Forensically, Mr. Olson's hand is in front of his thorax during bloodshed. Miss Olson's hand is between Mr. Olson's hand and the chest. What was she trying to prevent? We know that Mr. Olson wasn't doing this at the time of bloodshed. We know Mr. Olson wasn't doing this at the time of bloodshed. But a fist is consistent with the evidence. And we're going to look at that photo in just a bit. Curtis knew that he was under,
Object to him using the first name of the
Your
defendant.
names, please.
Mr. Reeves was well aware, based upon his training and experience, that he was in a very dangerous situation and that he had to act quickly because the distances between Mr. Olson and himself were minimal. And that awful things happen in fractions of a second. Fractions of a second. A tragedy took place that day. 2 tragedies. Mr. Olson died. The family lost a husband. Child lost a father. And Mr. Reeves.
Objection, Your Honor. This is inappropriate whether it's on the state's behalf or on the defendant's behalf.
It was a tragedy. And so what happens thereafter was also a tragedy of insurmountable magnitude. The investigation. We're going to go through every part of that investigation and analyze exactly what evidence you heard and what evidence you didn't hear. Alan Proctor, mentor of Aaron Smith, was not supposed to be assigned the lead detective role that day, if you recall. He said Detective Soto was supposed to be assigned, but he was on the other end of the county. And so I guess one of the supervisors said, okay, well, Proctor, you're on. He never even goes into the crime scene before he starts interviewing the first person. He never goes into that scene. He's the lead detective in this case. What do we think about that? And he ends up initially interviewing Corporal Hamilton and his wife. And so if you believe Corporal Hamilton, he will tell you 2 very important things. Corporal Hamilton will tell you that, number 1, he and his wife were interviewed together. Both of them. In other words, in his interview, his wife was there, and in her interview, he was there. And that somehow they had some special procedure going on, Detective Proctor, that before he turned on the recorder, he wanted to determine whether a corporal from the Sumter County Sheriff's Office, what he was going to say, whether he was of the right mind, I guess. And even Corporal Hamilton told you, you're not supposed to do that. You got to record an interview, record it from the very beginning, and preserve the evidence. Because remember, we're preserving the evidence not just for the prosecution. We're preserving the evidence for everybody. Prosecution, the defense, and most importantly, the community in our system of justice. And Corporal Hamilton, finally on cross-examination, says, yeah, Rick, you're right. Really, what I saw was a silhouette. Well, wait a minute. If all you saw was a silhouette, then what's this bit about, man, you can see 10 seats down, you can see 20 seats down. It's as clear as day during those previews. Why? Why can Corporal Hamilton only see a silhouette, never see Mr. Reeves, never see a gun? Because the reality is that it was dark. And why can't I provide you that evidence? Through no fault of our own. It was never preserved. Remember, Mr. Knox told you, light meter, noise meter, it's a no-brainer. Things have been used in investigations forever. But what was told to you here in this particular courtroom that's even more powerful? Do you remember, I believe it was Amy Parrish, if I'm not mistaken, it was the forensic tech that Mr. Michaels was interviewing. And she says,
Little
I've got
Miss,
a specialty.
who determines the jury?
My specialty is be able
Florida.
to actually photograph
State law.
accurately in dark areas. Now that's like a no-brainer, right? You got your forensic investigator right there. You got Detective Aaron Smith right there. You certainly want to, as all the experts have told you, you want to be able to stand in the shoes of Mr. Reeves and capture everything that he was seeing, everything that he was experiencing, and you don't do it. You remember their photography was such a disaster that they had to come back 2 weeks later, even under Aaron Smith's, remember he told you, my main focus there at the crime scene was I wanted to make sure that they had good photography. Of course, the spotlights that they needed were right outside in the parking lot of the forensic lab truck that they never used. Instead, they brought flashlights. So they bring flashlights, they don't use the equipment that's in the truck, and by all means, let's not use your expert that can actually photograph in the dark and replicate that lighting. So what do we do now in our criminal justice system when that has disappeared through no fault of the defense, but all fault of the government? He says it doesn't matter. You judge for yourself. So Mr. Proctor, Detective Proctor, now Mr. Proctor, he interviews both of those individuals, and clearly, from both of them, they tell him, hey, there's some profanity coming from that silhouette. It's coming back towards Mr. Reeves, and we don't hear a peep from Mr. Reeves. Unrefuted, clearly, profanity. The word, pardon, fuck, used in whatever way at that moment Mr. Olson was using it towards Mr. Reeves. Fuck! Does that indicate someone is mad? Fuck in a theater. Is that behavior that indicates that someone who's uttering those words has to be totally out of control? Who does that? Remember the environment. What's your environment? We're in a theater. You're supposed to sit down, enjoy the experience, watch the preview, watch the movie. Quiet. It's peaceful. It's relaxing. And someone is standing up in a fit of rage, acting like I would bet nobody in this entire room has ever heard before in a theater. Is that a cue? Is that a good cue? To understand that the gentleman, if you want to call him that had already attacked you once, is about to attack you again, was out of control. But that's not important to Detective Proctor. Because remember, he doesn't know what a structured interview is. He doesn't know what a structured interview is for a self-defense case. He didn't even want to know what Curtis's experience was in being able to recognize danger, assess that risk, and act accordingly. Please, ladies and gentlemen of the jury, please listen to that interview.
All right, we're back. We are back to the sex of Dr. Husel. Sorry, guys. Besides, you guys were not liking that, so.
Discharge summary is looking at the medical charts that kind of shows all of
Hey,
the
Critter.
medications that they receive.
So we're back to Jose putting in that work.
Okay. Now, going back to where
Teddy, I'd love to be that guy right now. I'd love to be Jose Baez right now. That'd be fun.
You had testified, I went through various names of individuals that you testified that under direct examination, you were asked about medications you gave during the care of specific patients, living patients, correct?
Yes.
And that was while you were attempting to keep these patients alive and utilize life-saving measures, right?
Correct.
Okay. So I think I got all of them, but I know I didn't ask you about James Allen. That was also one of the patients that you reviewed with the prosecutor on direct examination, correct?
Correct.
And the care that you were giving Mr. Allen at that time was not palliative care. It was the regular care while you were, I'm sorry, ICU care, correct?
Correct.
Okay. Now, you were also asked about Beverly Scherzinger. Do you remember that?
Yes.
Okay. And I want to ask you, but I want to kind of bring time into context. Bring that up first. No, this one. Yes, I'm going to show you Exhibit 3, page 749. You would agree that on the top right-hand corner, this patient is Beverly Scherzinger. Scherzinger, correct?
Yes.
Okay. And if we can scroll down to the very bottom. Do you see the date of October 9th, 2017 at 11:25 p.m.? Do you see that, sir?
Yes, I see October 9th, 2017. There's actually two of these dates, you know.
Okay.
There's
I'm
one of them.
Okay, both can't talk at the same time. She doesn't know that, you do.
I want to draw your attention to the nursing note on October 9th, 2017 at 11:25 p.m. Do you see that?
11:25 p.m. Yes, I see that. Yeah.
Okay. And this is basically a nurse's note that advises you that Dr. Husel spoke with the family at bedside. This basically indicates what's going on with the patient at this time, correct?
Wow. I wonder what patient this is.
It's up to the notes yet, yes.
So on
Hold on, let me work on the volume.
just
That's as loud as I can get the volume, guys. Hold on.
so we're clear, because I'm going to go back a little bit on this patient that you were asked about during direct examination. This patient was extubated.
What do you need an approach for? That's nonsense. Can you guys not hear them at all? I'm trying to find a booster thing here. Let me see. What can I do to fix the volume here? Settings, audio. I can mess with the mic volume. Yeah, that's on the stream end. Oh, little miss, are you watch? If you read the screen, it talks about them engaging Dr. Husel engaging in palliative care. So all that stuff he talked about earlier, it appears Dr. Husel does that and has been working with families. So this is bad because it shows apparently Dr. Husel has been doing this. He has been involved. Yeah, well, they objected, and then I don't think he's out of country. If I had to guess, he's probably got COVID issues or something, and they don't want to. They want to get him done. Although I'm a little disappointed he's testifying for court and he's in a fucking hoodie. Like, come on, dude, you need to be wearing a shirt and tie. He's unavailable. This is an interesting way of doing it, but I guess that makes sense nowadays in 2022. But yeah, now they're proving Dr. Husel does do all this stuff. So is he really breaking the rules, or is he just happen to be doing it in a different way than they're used to? This is why you have good defense attorneys. Uh-oh, it froze. Oh, wait, no, it's not frozen. Oh, are they still talking in sidebar? Yeah, I think they still were, guys. I don't know. I'm going to have to try to find a booster, volume booster. All right, guys, we're going to try this and see what happens. Oh, come on. Load the freaking audio up. Can you guys hear anything? I feel like I'm missing something. All right, hold on. Hate YouTubes. I hate dealing with this stuff some days. Let's try another stream. I'm just making sure that there's nothing wrong. Hold on, guys.
10 minutes off of my.
Let me know if you can hear the sound boosted up on this.
Does that look like a tan London fog jacket to you?
Let me know if that
How
sounds
can
louder.
Mark Turner believe in his own mind when he was this close to Mr. Reeves as Mr. Reeves passed by? And remember what he says about Mr. Reeves. Mr. Reeves said, "Excuse me." Probably the only thing he got right that day. How can Mr. Turner be so out of space, in orbit with this testimony? That's what happens. That's what the experts have told you happens. When you have a theater full of people,
Oh, come
they are
on.
in an emotional state. And as you're sitting there, you're hearing bits and pieces from every Tom, Dick, and Harry that is frantic about what just took place. And you're not having a single officer from the battalion that arrived immediately separating people, immediately interviewing people away from each other, and most importantly, also asking them at that very moment, tell me what you have done, who you have talked to, where you have been. And guess what? One other thing that would be really good. Let's get that straight. Let's get to see where they
Your Honor, I asked the counsel to make the argument for the podium is not up at the jury bench,
Let's,
or at least walk around.
my apologies. I will back up a little bit. Let's get that video still rolling.
Hang tight, guys. I'm sorry. I'm trying
Let's
to
see
get
where these
Husel back.
witnesses were.
This is pissing me off.
Let's see who they talked to. Let's get that video from the concession area. Let's get that video from Theater 11. As the experts told you, contamination is one of the worst things that could ever happen at a crime scene, and you cannot rely on those people that have been exposed. And especially
Is this louder? Can you guys hear it? Oh, come on. Is this louder? You guys can't hear it at all? All right, guys, I'm running out of ideas because I can't. Let me hold on. Try one more place. Pull one more trick up my sleeve. Is this better, you guys? Is this better, you guys? Can you guys hear things now? Oh, any better? No, the sound is going on the source. It's from the news. I've got the sound going. I'm listening to them talk. I mean, this I've turned it down and now I'm turning it back up. I can hear it very clearly. I only see it streaming on Long Crime. All right, well then we'll just go to Long Crime. I'll find where they've got it. Go from there. Critter, is it on Long Crime? Which Long Crime channel is it on? Okay, little miss, I hear it in my headphones, but I also hear every other thing I'm doing in my headphones. Anyways, Critter, which Long Crime channel is it on? Oh, there we go. Yeah, little miss, I asked you, what's wrong? Tell me what's up. Can you guys hear it at all? Oh. All right, guys, I think I'm going to stop for today if we're having this kind of a problem because I don't know what else I have to do at this point. Okay, I'm not going to stop streaming. I'm going to restart the stream. So I'm going to end this one and start a new one. Okay, guys? Give me like 2 minutes.